I'd like to introduce Dan Holmes. Dan Holmes is with the Building Water Health Program here at NSF. He's a business unit manager, right? Or business development manager. And he's going to talk about, what are you going to talk about?
NSF Standards and Development. Well, this is typical. I get up to give my little 2 cents and everyone leaves, so I'm glad to see that. So, first thing I would like to point out, 2 things. Water and gravity always win. So when you look at the boy there hanging onto the globe, there's a little bit of water on there. I'm in the water division here at NSF, and every bit of that water that's on that globe is important to us. NSF, our mission and focus has always been on protecting human health, improving human health. We develop public health standards. These were adopted by the US EPA to protect drinking water. We also test and certify products to these and other standards in the industry. I'm going to be focusing on the building water health side. I think there's a right here. So we're actually, I'm going to be explaining some of the standards that are under development and also some of the protocols. So with that said, there's a lot of things in development over the years. ASHRAE came out with 188. Some of the things that they said in the in 188 is you must have a water management team and you must implement a water management plan. And then the CDC came out shortly after that, kind of said the same type of message, and they developed a thing about how to develop a water management plan. And then they followed up with vital signs on a healthcare update, concentrating on that. Then ASHI, they've been around, obviously. Stephen Cutter was here. He was part author of this monograph. This is for healthcare, developing, again, a water management program. The World Health Organization has also put documentation together, and NSF has also been working in this area. So with all of these types of things, they tell you what you have to do. There's very little about telling you how to do that. And this is where there's a lot of confusion in the industry today. So we heard earlier from the CMS about some of the things that are coming up. Important things to note is that you're going to have a facility risk assessment. And it's not just Legionella. I know all the talk's been about Legionella over the years, but it's going to be other opportunistic waterborne pathogens. You're going to have a water management program, and you're going to have to specify testing protocols, and you're going to have to document. So with that, I was kind of curious if, with 10,000 people at the CMS headquarters there in Baltimore County, I'm confident they have already implemented a water management plan. Going forward, NSF Standard 444 is currently under development. This standard will not only reference ASHRAE 188 for Legionella, but we're going to be looking at all physical, all chemical, and all waterborne hazards within a building water system. Within that, it's going to include best practices for water management in human-occupied commercial buildings, institutions, including healthcare facilities, multi-unit residential and industrial buildings, and entertainment venues, i.e., stadiums and things like this. It's also going to carry means and methods for managing the risk of the disease and injury from water in a building, and requirements for documentation, record keeping, verification, validation, and what we refer to here on the certification side for auditing. And most of you here in healthcare side refer to it as surveys. I want you to know that this standard is going to be written to be prescriptive. It is going to tell you what you need to do and kind of how to do it. Of course, it's still in development. I can't tell you exactly what it's going to say at the end, but it's going to be all-encompassing. So some of the industry members that are part of this group, you have ASHI, you have the Aurora Healthcare Facilities, you Mayo Clinic, New York Presbyterian. We also have ASHRAE, Virginia Tech. We have the Department of Health, New York State Department of Health, the CDC, U.S. Department of Veterans Affairs. We have Health Canada, New York City Health Department, and more. These are all voting members or non-voting members that are taking part in this standard development. The standard itself is going to cover these 6 categories right now, or areas. So we're going to do premise plumbing, cooling towers, decorative fountains, pools and spas, on-site water storage, and ice machines. What we're going to be concentrating on is you want to look at the hazardous conditions within these water systems. Both you want physical and chemical conditions that contribute to the amplification of the hazards. Must be controlled to protect human health in a building. So all water systems must be assessed and inspected. How do those water systems, how are they operated? How are those water systems monitored? Which hazardous conditions can occur that may affect public health? We're looking at this in a simple acronym. Think of it as STAR. Most people can remember that. STAR would stand for sediment, temperature, age of the water, residual disinfectant. And if you can analyze the hazardous conditions within your building and looking at those four areas, you can determine what level of risk and stuff can be associated with that. I also want to point out that no two buildings are the same. Even when those are built as twin towers or identical buildings side by side, each building would need to have their own water management plan because the water that is used in that building is completely different than the other building. It's very important to understand, and it's been said earlier, documentation, got to have it. Defensible records and independent third-party validation are essential. And in the absence of clear defensible records, documenting that something was done, it's as if that something was never done at all. Don't forget the documentation. Say what you're going to do what you say, and document what you're doing. Cooling towers. So this follows under a protocol that we've written. It'll be published here shortly. This is on Protocol 453. This is on practical aspects of cooling tower treatment, operation, and maintenance. And it's another very prescriptive protocol on how to operate your cooling towers and what levels and when to test and so forth. Very short, condensed. It is designed to reduce the risk of Legionnaire's disease from your building water, minimize legal liability, increase the cooling tower efficiency, reduces long-term energy costs of building operations. A bad operating cooling tower eats up a lot of energy. Extends equipment life, helps avoid regulatory violations, especially in the case of New York City and the state of New York, which it is a regulatory enforcement now, and other states are looking at that right as we speak. And then independent auditing by an ISO accredited organization. Another protocol currently under development is NSF 376. This is for mechanical water filtration systems for microbial reduction. 376 is currently undergoing validation testing here, and this is to certify point-of-use mechanical filtration devices for healthcare systems. They're designed to reduce bacteria and fungi. The systems and components covered under have to first be covered under other NSF point-of-use standards for drinking water treatment units. They're not intended to evaluate systems which include disinfectant agents. You can see some of the bacteria and stuff that's part of this. So in conclusion, chemical, physical, microbial hazards associated with building water systems can be reduced with effective water management. All building water systems must be analyzed for the potential of the hazards, hazardous conditions that that can be in the building, and independent verification of your program implementation. So for some of you, when you came in, there was actually a booklet at the front reception desk that gives a lot more information on this. So on your way out, you might want to grab this. Talks a little bit more about what we're currently doing. There's also training that's available, and I understand that some training has been submitted through the University of Arizona to the CDC, which is a 2-hour course. NSF actually has available a 2-day course on how to develop water management plans. Day one is to give a full example of how to look over the hazardous conditions, what is part of those hazardous conditions. Day two, we literally break up the team members that are there. We put them 3, 4, 5 teams, whatever it is, and we give them a building that has all kinds of issues. And as a group, all day long, they go through and they have to analyze first. They got to do their process flow, or they have to determine who their team is, and then they have to do their process flow diagram, that one that everybody there can understand. including an infection preventionist that might not understand anything about a plumbing system. And then they have to go through and start determining what the level of those hazards, what their critical control limits are, and so forth. And then they're going to have to document it. And they have to do this on the premise plumbing side, the cooling tower side, and then they also are going to have, they present back to the other groups what their findings are. So this gives everybody that feeling of, okay, not only am I learning what I'm supposed to be doing, I'm actually implementing it so they can take this back to their facility and implement this. And then at the end of that, we give them a test. So that's the part people are most scared of. So anyways, I'm down to 18 seconds. I think I covered pretty much most everything I wanted to get. So I thank you very much. Appreciate it.
Thank you. Okay, next we have Darren Alcock from IDEXX. He's the Director of Global Marketing.
All right, thank you very much. I first wanted to acknowledge a couple of my colleagues. Patsy Root is here from Regulatory from IDEXX, and she's the one who asked the really good questions throughout the meeting. And then also Brian Swala is here, and Brian's certainly the person to go to if you have any technical questions. I drew the short straw, so that's why I'm up here. So chances are you probably haven't heard about IDEXX before this meeting, but if you own a cat or a dog and you've ever had to take your cat or dog to the veterinarian, very good probability that the vet is using IDEXX diagnostic tests to make sure that your pet is healthy. But IDEXX also is the worldwide leader in water microbiology, the manufacturing of water microbiology tests. In fact, 2.5 billion people every single day rely on IDEXX tests to make sure that their drinking water is safe. So we're not here to talk about dogs, and we're not here to talk about drinking water, but we are here to talk about Legionella. And I want to thank the speakers before who went through you've seen this slide a number of times or variations. So I'm not going to spend a lot of time on it, other than to say I think Dr. Weir summed it up best in that Legionella pneumophila is now by far the most prevalent waterborne pathogen that we have. So last year, we did some market research. We wanted to understand, what does the water testing market for Legionella look like globally? So if you say that the amount of testing for Legionella in water in the United States is X, it is 19 times higher per capita in the UK. And Jimmy just recently left, but the reason is what he talked about, their commitment to water safety plans in the UK. Similarly in France, it's 22 times higher than it is in the US. And the country that has the most aggressive regulations in place for testing in water systems is Germany. Every single building that is bigger than a single family dwelling legally has to be tested for Legionella at least once every 3 years. So there's a significant amount of testing that's done in Germany. So despite that gap, you've heard a lot about this. I won't go into this. A lot of good things have been happening in North America with ASHRAE, CMS, and then also regulations specific to New York and cooling tower regulations in Quebec. But for us to close this gap, there needs to continue to be more things happen. There needs to be adherence to ASHRAE and CMS. And I think it was Dave Krause who said, he put it best, he said, the only way to validate that your water safety plans are working is to test for them. So that has to happen. Right now, the EPA doesn't regulate Legionella pneumophila, but it is something that they're looking at. So this is an important slide. Even though there are over 40 species of Legionella. This is primarily and almost exclusively a disease, Legionnaire's disease, associated with Legionella pneumophila. In water systems, about 90% are Legionella pneumophila. But more importantly, because this is a pathogen, and this is data that just recently came out, almost 4,000 sputum culture confirmed cases, 97% were Legionella pneumophila. So current methods are very complex, which you don't care about unless you're a microbiology lab. But what you should care about is they're very inconsistent. And it can take 10 to 14 days. Legionella is very slow growing, so it can take 10 to 14 days for a confirmed test. There's lots of judgment and interpretation, so the results can be quite variable over time. And then the last slide, this year we launched at IDEXX a next generation culture test, which is really a breakthrough and ideal for routine monitoring in hospitals and buildings. It's a 7-day confirmed result for Legionella pneumophila. It's highly specific. It's so easy, and you can see the protocol, the base protocol. There are hospitals that are actually doing testing in-house using this method. And we also have a very similar test for Pseudomonas aeruginosa. And in the UK, where testing is mandatory in hospitals, a number of hospitals are using Pseudalert in hospital for testing Pseudomonas aeruginosa. And then the last point is just to say the most important data is really the bottom point. The data shows it's 99% reproducible and repeatable. And when you're thinking about doing trend analysis, which you want to do in a hospital, that is the kind of data that you really want to have. So I would, if you have any questions, please reach out to myself, Patsy, or Brian. And we also just recently did a webinar with the Association of Water Treaters. A lot of really good information on Legionella. So if anyone is interested in that, I'd be glad to send the link. Thanks a lot.
So a few different technologies coming together, about a dozen different types of things, but the concepts of fast-acting self-sanitizing surfaces near the patients, continuous persistent self-sanitizing surfaces, although it could be much slower, floors, walls, ceilings, and frequent, fast, immediate episodic disinfection. My goal would be to see things automated in hospitals that don't require human intervention, that don't require, the excuse of we can't afford the staff, et cetera, or don't require behavioral change to make a safe environment for our patients. So just like we have self-driving cars now, I'd like to see self-disinfecting hospitals in the future. And I'll just show you some of the things that we've been working on. So one of the first things we did, copper-coated surfaces. And this is just one of many products that could be out there. We've focused on a toilet seat because a lot of bugs are bathroom bugs. And all the medical device manufacturers out there, the people that make beds, et cetera, IV poles, they're looking at adding antimicrobial surfaces now to their products. We didn't see the toilet guys as focusing on that. So that was one of the first things that we came out with. So kind of a low-tech solution, although the application is fairly high-tech. And we know the EPA is working on a new protocol for that, so that's why I've showed a 3-log reduction within 1 hour, although currently to make public health claims, it's a 3-log reduction in 2 hours. Sinks are a big issue. So right now, if you put 500 new hand hygiene sinks in your hospital, great for trying to prevent C. diff in your hospital, but you got 500 new points of possible outbreak from CPE, CREs, et cetera. And of course, dead legs, you could have Legionella. So this is a collaborative effort with a large sink manufacturer. So this sink is smart, it's programmable, it auto flushes, and it creates ozonated water at the point of use. So now you're washing your hands with a disinfectant. Even if you have poor technique, you're still going to disinfect your hands better than if you were to use soap and water with good technique. Most importantly, it's disinfecting that drain all of the time. It eliminates the possibility of biofilm. It reverses biofilm if it was there to begin with, and it prevents any possibility of CPE, CREs being released from the drain, and in Canada, et cetera. Another collaborative effort, we looked at making bathrooms auto-disinfecting. So with this device, we have motion detectors, we have magnetic door contacts, some smart software. We know when patients are in doing their business, we know when they leave, and we flash the room every single time a patient uses that bathroom. And every 4 hours throughout the day, even if people don't go into that bathroom. And we've had some great success with that. One hospital out of Vancouver, we had 12 patients per bathroom in this one tower. So we had 120 patients that were getting 15 cases of C. diff per month. And by installing this in their bathrooms, we reduced it to 1 case of C. diff per month because we eliminated that common point of discharge. This is kind of the next evolution. This is towards the self-disinfecting hospital, so a self-disinfecting patient room where we have a magic eye in the sky that's watching everything that's going on, only it's not watching it with camera imagery. It's thermal imaging, it's advanced occupancy sensor. It knows not just that there's a person in there, it knows how many people are in there, what they're doing, et cetera, et cetera. And it allows a patient to push a button and disinfect her own room. She just has to get up, go to the bathroom, and a room is disinfected behind her. And you can set it in an automatic mode so that every time that room is empty, it's being disinfected. We have a couple of really good examples of putting a group of technologies together, a bone marrow transplant trial that was over a year, about 15 months. Not one patient received an infection from the physical environment during that period of time. And we have the Ontario Ministry of Health right now making it mandatory, this type of technology, whenever you have 2 or more patients in a room and you're developing a new high acuity level, like a stem cell transplant, malignant hematology, et cetera. And that's it.
Good.